I want to show a similar but slightly different situation. This patient, 64-year-old female, she was on vacation. She was also found to have abdominal pain and rupture. However, instead of having a solitary tumor, you can see she has multifocal bilobar disease. Doesn't have cirrhosis, but these are biopsy-proven HCC. Maybe there's 5 or 6 that we can see on this picture here. She was taken for emergent angiography just like before. We did the angiograms, and at least to my eye, and I'd love to get your thoughts too, Sid, there looks like there's more tumors on the angiogram here than we saw on the CT scan. It looks like almost on the left screen, almost a miliary pattern where you can see a bunch of small little tumors throughout. I don't know if you have a similar...
Yeah, I mean, I agree. This patient's got diffuse multifocal tumors. They've ruptured. Their prognosis, short-term prognosis, you can still be reasonable, but their long-term prognosis, no matter what you do, is poor, right? And so just like you did here, we would do an embolization. I think it ends up being dealer's choice in terms of how you embolize this, whether it's particles or gel foam, et cetera. The embolizations tend to be quite effective in stopping bleeding. Then the question becomes, what do you do next, right? And that's not so easy.
On the post-scan, you can see extensive necrosis, particularly of the dominant tumors on the right side of the liver. The left side tumors are still viable. They weren't targeted because they weren't ruptured. However, now we have 3 small tumors that we can see on this MRI. What do we think? More locoregional therapy, systemic therapy?
Patient stable? They're patient stable, outpatient
now? This is 2 months later.
2 months later. So I'm assuming they haven't at least yet declared peritoneal disease. So, we would still consider locoregional therapy at this point, but then everything has to come on the table. Like, are they a transplant candidate eventually, right? Clearly not now, but if they're downstage, do they have peritoneal disease where they would need systemic therapy? And so on. We would probably do some kind of embolization, whether it be a TACE or a radioembolization. It's hard to say. We would have to do a mapping angiogram and determine that. I would lean away towards ablation because this patient has multifocal. It's not just the 3 tumors that are highlighted. There's definitely more than 3. So doing an ablation on the 3 that you can actually see is not really in the patient's best interest.
Mm-hmm.
I would advocate for systemic therapy for a person like this. I mean, unlike the last case, the cat's at least starting to come out of the bag here. We have multifocal disease. Obviously, she's also at risk for peritoneal seeding. And I think similar to our prior discussion, I think you lose little by starting with immunotherapy here, seeing where things head, of course, considering additional locoregional therapy to some of those lesions that may or may not be responding is always on the table if it needs to be. And then again, similarly, would not offer bevacizumab with a recent rupture, but could potentially be a good candidate for STRIDE.
I would say it's probably worth mentioning that, downstaging and getting to transplant, the burden of proof that the cancer was, completely controlled to pursue transplant is pretty high in a case like this. It wouldn't qualify for the standard exceptions, but you'd have to really watch this person.
And I'm assuming you'd have to give some tests of time, like 1 to 2 years.
Yeah.
Before you could.
And I don't think there's a hard answer about what that time is exactly, but it'd have to be a real long time to make sure.
I agree with that. The dogma used to be rupture equals no transplant. I think we've been a little bit more thoughtful about that, not lumped everyone into one basket, but you still have a high burden of proof to get past it. I just wonder if you go back to the last image there. I mean, you guys, I feel like we're on the Matrix where you see these screens coming, the numbers, and you guys are reading it. That's a miliary pattern. And I see, all I see is I was like, oh, is that the kidney?
Yeah.
It's the same when, our transplant surgeons send me pics of the surgical resection. I'm like, I don't know what's head and tails here. Okay, so it's the same way.
Got it. Okay.
And we have to have some magic too. We can't have you, doing all of this.
Appreciate that. Yeah.
So we decided to go with STRIDE for the exact reasons. She ended up having a recurrence, particularly in segment 5, where it was about 3 centimeters. We did radioembolization, as you can see the cone beam CT there, and had a complete response. And so she's doing well. This is about a year now after radioembolization. She's continued on immunotherapy. She's having no side effects or issues with immunotherapy. Do we consider immunotherapy indefinitely? Do we have a stop date? When do we consider transplant, if ever?
I'll start. We don't know the answer for these patients. The other thing I will just add is that I know you gave us the caveat that everyone has, good liver function unless told otherwise. This person has 0 risk factors for chronic liver disease and is more physically fit than anyone at this table. So what is the best answer for someone like that that's extremely healthy, now has NED? And for me, when we don't know the answers to these questions and you have a patient that's capable of shared decision-making, it's being very honest with them that, look, if you're nervous and want to continue immunotherapy for the short to medium to long term, we'll do it. If you're tired of this and want to break after a year or two to see how things declare herself, let's do that. But I'm curious too as to Heather's opinion here on would a transplant benefit her at this point?
Assuming that with everything that's been done to her liver is, still in good shape, then that's an oncologic question, right? She doesn't need it for, liver function. It would be more a matter of, would that give her a better durable response to the cancer than, any other approach, including continuing her immunotherapy on an indefinite basis.
Yeah, these cases on the margin are really interesting, and we just don't know the answer, right? So I think this is an area that's really, it's going to be interesting to see how this progresses, how this develops over time, because you're right. I mean, the immunotherapy can go on indefinitely as far as we know. Is that
It could.
fair?
We also could stop and she could never recur.
Right? Yeah. So how do you decide when to stop? Because that, to me, I would be like so nervous that she's going to blossom and pop up. And then the other question is, if they do stop and you see disease come back, how responsive are they to restarting that same immunotherapy? Or do you have to switch?
We can re-challenge and get a response. Obviously, these are small numbers of people. It's not like we have these enormous case series, but we know either from other tumor types and melanoma, for example, where our kind of history with immunotherapy is a bit longer, that patients that stop immunotherapy that are re-challenged can respond. I would not feel comfortable stopping any earlier than 1 year after her tear. 2 years would probably be better, but it really is a bit of a judgment call based upon how everyone's feeling at the time.
I guess my one plug for pushing for transplant in this case, I'm trying to think of patients where I've seen 10, 15, what are more tumors, and you got an NED and it didn't ever recur again. That doesn't happen. I mean, that happens like in fairy tales, right? So this patient is going to recur, whether they're on immunotherapy or not. You had that many tumors, the chances of them not recurring are way less than 10%. So my push would be for a transplant where now your post-OLT recurrence becomes sub 10%, assuming you have, not fulminant HCC at the time of transplant.
I think I agree with you in some sense. I do worry in that scenario, though. You're now subjecting a person to a treatment that, yes, we historically think of it as providing long-term durable disease control, but we're now immunosuppressing her. Is that the trigger that causes her to recur? And then I know that she's very immunotherapy responsive now. Immunotherapy becomes off the table post-transplant. And if she does recur, we run into a whole lot of trouble. So I think those are all the variables to think about. But you're right, there's no right answer. And
even you mentioned in the 5-year survival for now the immunotherapies is what?
20%.
Right. So that means 80% are dead.
But we know
years,
that
right?
people that are responders are driving that curve, that tail of the curve.
But it's still not, what's the 5-year survival after a transplant? And again, this is a difference is 80%, right? So when I think about those numbers, and again, we're not talking about 80% of these patients, right? That this might be a very different patient
that's
population.
80% of all comers.
Of all comers,
I don't know for
absolutely.
her. Yeah.
So, but we're talking 20% at 5 years for immunotherapy, 80% at 5 years for transplant. And again, it's not a fair comparison, but it is two very different ends of the spectrum in terms of overall survival. So that's why in this specific case, I think there's no right answer here, but to me, like this patient's going to recur. There's just a matter of time.
That was great.
Hot one.
Yeah.